Good afternoon. Good afternoon. My name is Eva Yin. I'm a partner with Wilson Sonsini. It's my pleasure to be moderating the health pitch competition today. I specialize in FDA and healthcare regulatory law at Wilson Sonsini. And I did my PhD at Yale, so it's great to be back on campus. Today we have 7 judges. In the interest of time, we'll just dive in. So each team will have 5 minutes to present, followed by 3 minutes of Q&A with the judges. And as a heads up, so we will go over the time. So if you can stay for all the presentations, that will be greatly appreciated. So with that, we'll start with the first presentation about voices.
Hello and good afternoon. Hello, I'm Fuad Abujarad and I am an Associate Professor of Medicine and Public Health. I would like to talk to you about our intervention for detecting and preventing elder mistreatment. It's a digital health tool called Voices. Elder mistreatment is a major public health problem where 1 in 10 older adults is a victim of elder mistreatment. Common forms of elder mistreatment include emotional abuse, financial abuse, and physical abuse. The main problem is we only know about 1 in 24 problems. The other 23 problems still unknown and undetected. And the reason is elder mistreatment in most cases come with no signs. It's very difficult to detect. Victims themselves are not willing to disclose because of stigma, fear of retaliation, and fear of getting loved one in legal trouble. The healthcare providers are busy. Although they're mandatory reporters, they lack the tools and they lack the time to screen for elder mistreatment. These are not my slides, so I'm sorry. I'm just trying to figure them out. So in it's not clicking anymore. Okay. All right, we'll proceed. So we started a paradigm shift in targeting elder mistreatment. We focused on the older adult themselves by developing a tool that educates older adults on the risks, the signs, and the consequences of mistreatment. Our tool Voices screens, educate, and provide a motivational interviewing to motivate victims to self-report elder mistreatment. So Voices is one-time 8-minute intervention that motivates older adults to speak about elder mistreatment. In our work on it, we secured more than $2 million from NIH to design and develop Voices. We conducted 5 clinical trials with more than 1,200 patients with or without dementia. Our result shows that Voices is loved by patients. They find it usable, acceptable, and from the 1,213 patients who used Voices, we have 68 patients who wanted to disclose their mistreatment to their provider. Now, this is 68 compared to 0 because usually those patients are missed and are not discovered by the healthcare team if it was not for Voices. So in the funding from the Vatnik Award come at a critical time when we are trying to commercialize voices. The funding will help us first move voices to commercial servers, then modify voices to allow for multiple customers, and prepare training material for healthcare providers. We will also want to start planning for commercialization of voices and do initial market research. Thank you.
So next, I'll turn to the judges for questions.
Do I need a mic or can I just? I can have one.
Here's the mic, though, just happen to find one there.
Thank you for an interesting presentation here. So who will be the one paying for your solution? How do you expect it to be reimbursed or paid for?
Yeah, so I apologize, these are not my final slides. My slide set has the payers. So we look at healthcare providers, including hospitals, primary care, urgent care. They're in need of this. We're currently implementing it at Yale Health New Haven system. We also look at the buyers who are interested in reducing risk of elder mistreatment and avoid bad health outcomes. The VA, nursing home, long-term care facilities are also interested in this product.
What exactly is the product?
So the product is a digital health tool that uses digital coach that runs on tablet that walks the older adults. They use them themselves. You don't need somebody to help them. It's self-administrated. And they go through training on what constitutes elder mistreatment, then a screening to identify if they have likelihood of becoming victims or are they already victims. And then it does motivational interviewing. It's one of its kind automated motivational interviewing to encourage them to talk. Because of stigma, they usually want self-report.
Is it an app? I mean,
It's a web-based app that is device agnostic and it can run in any platform.
what prompts me then to download this or go to this? Like, wouldn't I already have?
No, it will be like a service for pay. It won't be like the app, you download it yourself and use it. A health institution or a long-term care facility will subscribe to it and they will charge per single use or maybe different kind of packages.
And then the alerts or the information that gets reported to whom?
So once the patient use voices, the goal of the voices is to encourage them to declare their victimization. They will notify
Back to a provider, back to
the nurse or the provider. They will tell them, I want to tell you about my victimization. Usually after they give them voices, they will ask them, is there anything you would like to talk about? And then they would say, yes, I want to talk about it. The other benefit of voices beyond detection is that voices improves the knowledge of elder mistreatment. This reduces risk of bad health outcome and risk of victimization. So a user who goes through voices are more knowledgeable now of the signs and the risk of mistreatment, and they can protect themselves. So it has a preventive plus detecting. Thank you.
Thank you. So for our next presentation, you will hear from M-Select.
M-Select is mental health data that connects the dots. I'm Dr. Amber Childs, and I am an expert and national leader in evidence-based, data-driven behavioral health, and I'm the founder of MSelect, which you can't see here. But listen to me, $13.9 billion. That is the total cost to treat mental health problems in children in 2012, making it by far the costliest health condition in youth. And 60% of these costs were being spent on adolescents aged 13 to 17. The CDC data have shown us that in the 10 years before the pandemic, rates of depression and deaths by suicide in our adolescent population had skyrocketed. And on Valentine's Day this year, we found out the effects of the pandemic with the highest reported rates of depression in a decade showing up in our adolescent females. The data could not be clearer. Our youth are in crisis, but the simple fact is most teenagers don't get the evidence-based treatment that they need, and so the crisis and the costs continue to rise. Evidence-based treatments are proven to reduce symptoms while also reducing the costs associated with poor outcomes. And when you add a routine measurement practice, it actually amplifies those benefits. Teenagers need evidence-based treatments that include routine assessments to deliver brief, personalized interventions right where teenagers are most likely to seek out help, which is online. And they need those data to work hard for them, to connect the dots between that teenager to their care provider to their caregiver so that everyone is benefiting from those data-driven clinical insights. And that is exactly what we designed MSelect to do. Here's how it works. Emma is a 15-year-old. She's going to log her symptoms of depression using a brief standardized assessment. And then MSelect, using those self-reported data, is going to provide her with targeted feedback and then connects Emma with brief, science-backed, interactive treatments that are customized to her standardized data. And it's going to adjust those treatments and solutions over time according to her routine standardized assessment as well as her engagement with the app. MSelect is also going to connect the dots back to that pediatrician to provide those data to that provider. And it's also going to give that provider clinical decision-making guidance that is integrated into the electronic health record, making Emma's visit more precise, cost-effective, and efficient. And Emma's mother is also going to receive data-driven clinical insights specific to her daughter's measurement so that she understands best how to support her daughter's wellness through a parent portal. Now, MSelect gives providers 3 key benefits. First, electronic integrated healthcare clinical decision-making support gives providers the ability to provide high-quality, efficient care. Second, providers can capture additional revenue through payer reimbursement by dropping billing codes that are made for routine standardized assessment. Now, these billing codes are not a hypothetical exercise. This is not a drill. They are active and available and approved for reimbursement through CMS. I could leave here right now and drop that billing code and be eligible for reimbursement. And then finally, in an increasingly value-based healthcare landscape where reimbursement depends on measurable quality rather than volume, MSelect sets providers up for that optimal reimbursement. And you don't have to take my word for it, because I have asked providers and they say that MSelect would allow them to provide an impact beyond medication. It would jumpstart their treatment, and it ensures that data is not going into a black hole or into a treatment vacuum where treatment is happening outside of the purview of the provider. Now, you might be asking yourself, why do we need another digital mental health app? You could probably name 10 off the top of your head that you don't see here on this app right now. And while mental wellness apps do have a place, fractionally few of them include any evidence-based strategies, and even a smaller proportion of those include any evidence-based intervention that has undergone rigorous testing to prove its clinical effectiveness. And then finally, there are a number of measurement feedback systems on the market that promise providers to get the data integration loop that they need to make these impacts. But here's what I know. MSelect is the only solution that connects the dots to integrated measurement, clinically proven, rigorous, evidence-based treatment, as well as wellness strategies to improve outcomes. So within the first several months of formation back in January, I have secured $150,000 in non-diluted funding, built an initial team, and we are well underway with our initial stages of product development. And we have partnered with a software developer to really think about platforming this on a HIPAA-compliant platform. ImSelect has the team that we need to drive success even in these early stages, and we've partnered with a development team. I'm going to keep going because it messed up in the beginning for me there. Listen, I got to give my full 5 minutes. Now that So here's where we are right now. We have a clear integrated clinical strategy, check, complete. We have content development that we have built that is according to our clinical algorithms that we know work for depression. And now we have identified a HIPAA-compliant software partner, and these Blavatnik funds will really help us to protect the data that we get from patients so that we can go to that next step of validation. So connect the dots with ImSelect.
Judges?
Yeah.
You can get your full 3 minutes of questions.
Great presentation, very engaging, very clear. I want to drill into the CPT code you mentioned, because obviously providing a financial ROI to providers is important to adoption, which you've identified. And so I'd love to hear what that CPT code covers, what needs to be done, and a little more color there.
Yeah, absolutely. So if any of you were at the panel yesterday, what did we hear? What we heard from panelists was 1, data is gold. 2, we need to make things seamless for providers. And then 3, we need to really look at the reimbursement pathways to ensure that we're actually able to get this done. So that CPT code is approved by the Center for Medicaid Services for routine standardized assessment. You can capture $5 per every single time that you drop that code. It is actually able to be used currently in primary care for screening. And so if you're having a person taking these assessments once per week, which is what we would do for measurement-based care, so you might have picked up that this is measurement-based care, then a conservative estimate for someone who is working as an individual provider in this practice could capture up to $8,000 per month, even if teenagers are actually only completing 2 out of those 4 assessments per month. So that would be the reimbursement pathway. Now, those E&M codes that you would drop that with, your evaluation and management codes, are already ready in primary care. There's still some work to be done in the behavioral healthcare space, because right now the NCCI won't let you drop those codes more than once and be attached to a psychotherapy CPT code, but the American Psychological Association is actually advocating to have that adjusted, and I sit on that board.
Can you talk a little bit about what is sort of...
Uh-oh, she had a question.
I'm sorry. Go ahead.
So, great presentation.
Thank you.
Very articulate. I second that. How do you think about fostering the engagement on the patient side? Because that's a necessary component for this whole thing to work.
Has anybody ever tried to engage a teenager in something that they didn't want to do? Yeah, I'm really good at that, actually. So what it turns out is if you try to put a suit that's made for an adult on a teenager, not only does it not fit, it's not giving what needs to be gave. If I was a teenager, that's what I would say to you. So what we have to do is we have to use gamification principles to really ensure that teenagers are engaged with this app over time. What we know from the basic science for measurement-based care is that if you give somebody feedback about their data, they are already more likely to be engaged. That's just what the basic literature shows. And if we can design the treatment in a way that is resonant with the youth sensibilities, that is to say, it looks a lot like Instagram and TikTok, but it actually has evidence-based facts behind it, then we're more likely to be able to get teenagers to be engaged. So we also have things like streaks, we've got badges that you can earn, and then these interventions are delivered in these very small doses so that we're able to capture their attention. Happy to hear from you.
It's 2 minutes or 2 seconds. Unfortunately.
Sorry, Owen, you'll have to catch me after. Thank you.
Thank you.
Thanks for being patient while we're going through the technical difficulties of loading. So the next you'll hear from Lifewell.
Good afternoon. This is LifeWell, Digital Lifestyle Medicine. So poor lifestyle behaviors account for the greatest percentage of healthcare spending in America. Nearly all U.S. adults have one of these poor lifestyle behaviors, and among those that do, most have 2 or more. They are very costly to the healthcare system, and they are a significant burden to individuals, but importantly, they are fixable. So what am I talking about when I say poor lifestyle behaviors? Heavy alcohol use, tobacco use, drug use, poor sleep, poor diet, physical inactivity, stress, and poor emotional well-being. We can all take stock of how many of those we have in the room. And this is where lifestyle medicine comes in. If we can improve these health behaviors, we can wipe out nearly 40% of healthcare costs. Lifestyle medicine is preventive healthcare and self-management focused on helping people improve their lifestyle behaviors. And we have a solution. This is how LifeWell works. For the user, it's a smartphone application that allows individuals to track their lifestyle goals, to track their lifestyle goals, to track their behaviors using diaries and active prompts, passive smartphone sensing, and to connect wearables if they use any devices, and to change their behavior using evidence-based tools and coaching. And on the back end, we crunch your data using machine learning and math algorithms to generate your unique integrated lifestyle profile and derive actionable insights to promote lifestyle behavior change. Our holistic approach decreases stigma. It reduces the stigma around any given lifestyle behavior. Basically, for example, a lot of people who have an alcohol problem feel a lot of stigma if they have to go to an AA program, but to use something like a smartphone app would feel a lot better. So it reduces the stigma around any given lifestyle behavior. It's adaptable. You start where you want. We help you to discover the lifestyle behaviors you didn't know about. So for example, learning that your sleep problem may be related to your alcohol use. We validated LifeWell in 2 NIH-funded trials in nearly 200 young adults. Participants saw significant increases in their healthy behaviors and significant decreases in their unhealthy behaviors. So what is the experience for a user? Let's walk through this participant example so I can walk you through what someone might experience. So the next day, a young adult records their behaviors from the day before, including the total number of drinks that they may have consumed at a party. These drinks are then quantified into an estimated blood alcohol score. This score is then connected to their other lifestyle behaviors, such as their diet, their sleep, and potentially other health biometrics, such as their heart rate. Tailored advice, coaching, and evidence-based tools are then offered to help them lower their blood alcohol level at their next drinking occasions, as well as to reduce its negative impact on their health. So as others have mentioned, just like the person before me, there are companies obviously in this space. These are our key differentiating factors. We address all lifestyle behaviors together. We decrease stigma. You come into a general lifestyle program rather than having to come into an alcohol program. And we emphasize lifestyle risk discovery. It bypasses the need to self-identify that you have a problem. We help you to discover the problems you didn't know about. So as all of you know, the current US healthcare market focuses on paying for specific conditions and paying for specific behaviors. So our go-to market strategy is really going to focus on addressing the areas of greatest need and then expanding to other categories as the company grows to ultimately address the entire spectrum. So for our first addressable market, we're going to focus on addressing heavy alcohol use with young people. And we're going to work with colleges to roll out alcohol reduction programs. These are actually great programs to go after because they're typically well-funded programs looking for real solutions. And in line with how colleges structure these programs and offer them and pay for them, we would offer this to all students, for example, all incoming freshmen, and then as a referral for those students with more problems. From there, we would then expand to pre-surgical lifestyle medicine and address what are often mandated behavioral requirements before surgery, for example, smoking cessation and weight loss. And here we really want to augment what we already do at Yale New Haven Hospital in our clinic by offering these services with a digital solution. From there, we would then expand to chronic disease lifestyle medicine and addressing lifestyle behavior change longer term with individuals with more chronic conditions. And again, to already augment the work we do at Yale New Haven Hospital and at the VA with patients with cancer, liver disease, and diabetes. Our multidisciplinary team includes experts in lifestyle medicine, bioinformatics, digital health, and computer science. And for the Accelerator Award, we would focus on de-risking LifeWell. We provided intensive daily interaction in our clinical trials. Now we want to offer the same benefit with a lighter touch and demonstrate sufficient user engagement and recency and frequency evidence needed to support LifeWell's success.
Great presentation. So there are a lot of programs out there that have been proven for years and years with sort of group, AA, group counseling, whatever. So how do you think about going up against what has been a pretty well-established format with peer counseling, group counseling, et cetera?
So taking young adults, for example, a lot of young adults don't necessarily identify with going to AA. And when we think about, alcohol use disorders or alcohol problems, excessive alcohol use, we think of it as an iceberg, with the riskiest people often being at the top, but the majority of us actually being in the middle. And so young people, for example, often don't really think they have an alcohol problem because they look around at their peers in school and they say, well, this person's drinking more than me, so clearly I don't have a problem. So we think this is really has broader appeal for the majority of people who often don't even know they have a problem, and it gives you sort of a novel on-ramp to kind of come in the door. We kind of started this program initially because if you take a lot of alcohol programs that are offered in colleges, for example, you can go on Reddit, for example, and read about UConn students drinking during the mandated requirements that their colleges have for them. And clearly they're missing out on a lot of benefit that they could gain from a program that would engage them better. And so our experience has been, if you bring them in the door using a more novel on-ramp like wellness or well-being, they're more likely to engage with it, they're more likely to gain something from it. They don't necessarily at the door identify that they have an alcohol problem.
Thank you for a really good presentation. Instead of going for the young adults, have you considered going for another group if it's for alcohol treatment or guidance? Because I would say that there are more obvious groups that would potentially be more inclined to seek for this kind of help.
Yeah, I mean, as I was mentioning, we see ourselves kind of starting, with a small group that we've already had some success with, and then starting to expand out. Somebody who has a more established alcohol problem, I would think of as more of a chronic disease population. So we definitely think there are other populations to target. We've had success already with young people, so that's kind of why we wanted to continue with that. But that's where we also would be looking for guidance and connections to get support for how we should structure this and expand.
Happy to ask a question. How do you think about the payers in this?
Yeah, so we set ourselves up for colleges because they already have annual licenses that are like $40,000 that they pay for these programs. But once we go, into a bigger situation like lifestyle medicine for chronic disease or pre-surgery, I think there's a number of avenues. There are the CPT codes that have already been mentioned. There are CPT codes for lifestyle counseling. There are CPT codes for digital therapeutic monitoring, patient monitoring. But also, we can go sort of the Hinge Health route, right, where we offer this as an opportunity for people through their employers, where you have a base program, and then based on your participant involvement, you then pay a higher price.
Thank you.
So for our fourth presentation, you'll hear about stretch text.
Hi, I'm Stephanie, and this is my PI, Rebecca Kramer-Batiglio. She'll be showing some things as we go along. So remote health monitoring is an extremely exciting new area in wearable health tech. It can monitor things such as chronic conditions, post-op recovery, diagnostics. But what's missing from all of these, and what can make this so much more impactful, is wearable real-time motion tracking. And we've actually found a niche in this space within diagnostics, and that's actually sleep studies. It's kind of surprising. The current standard is polysomnography, but it's obtrusive. It suffers inaccuracies from the first night effect, and it's expensive. Insurance companies and patients can pay up to $3,000 out of pocket for something like this. And $9 billion are spent annually on this kind of sleep-related diagnostics. And they diagnose some really essential disorders like limb movement disorder, restless leg syndrome, and REM sleep behavior disorder. REM sleep behavior disorder has actually been known to be a key predictor of Parkinson's disease. So we've talked to many researchers, and they've confirmed that early and widespread diagnosis of RBD can actually increase patient lifespan and quality of life overall. But we cannot do this without an unobtrusive method for sleep motion sensing. Like I said, the total addressable market for all of sleep studies is $9 billion, but by calculating from the bottom up using CPT codes and other metrics, we think we can try and capture about $1 billion of this right now. Not to mention the $12.1 billion in potential savings from early diagnosis of things like Parkinson's disease, where we can actually reduce the impact of this disease. And so we've done a lot of customer discovery in this space in and around Yale, and found that patients do suffer from sensor discomfort during this procedure, that researchers want a better measure for this, and that doctors also want more accurate and faster diagnoses. And so we've determined that clinics really need a tool to diagnose sleep-based movement disorders where the patient feels comfortable, and that's at home. So we're StretchTechs Incorporated, and we want to leverage breathable, wearable, whole-body motion sensing to revolutionize sleep disorder diagnostics. And we do this using two key technologies in the lab. The first is breathable fabric strain sensors. Our model here, and Rebecca's showing it, is wearing sensors integrated into their clothing. And this data output can help us reconstruct the human body and pose during sleep. And the Amazon garments that we bought are actually an integral part of this sensor. They're part of it. And so if you have sensors, you need circuits. And they're usually something like this, a rigid single board computer that's processing sensor data. And we've made a completely stretchable soft version of this. And so we want to use them together, and that's exactly what we've done. In the area of highest strain on the human body, the elbow, we've integrated a sensor that's outputting data to this soft Arduino to give a clearly alive visual output. And so in the future, well, we have a suit in lab right now that we've been using, but this sleep garment would take stretch data, put it back into the computer, and use motion processing algorithms to detect these motions so doctors can give you a clinical diagnosis. And we want to use our traction with patients, clinicians, researchers, and doctors locally to start beta testing, and that's what we need this funding for. We want to use the first $20,000 to make 20 sleep suits. That's not saying that it's $1,000 a sleep suit. It's actually only about 100, but the rest are fixed costs. And then we want to use the next, and so we eventually want to send product samples to clinics. And next, we want to use the next $10,000 to actually take our suit to key opinion leaders in the field, get their feedback, and then develop the suit, all the while making other relationships to eventually generate revenue, making relationships with clinics. And so we also see several key other needs in society for this kind of wearable motion technology. Like, for example, athlete performance and analytics. It's a huge field, but we want to take that kind of tracking out of the lab and put it back onto the court for athletes. And then completely autonomous fitness tracking, another huge space, but there's no tool that you can buy that can tell you how many squats you've done, for example. Weightlifting is a huge missed opportunity, and we want to be able to give that feedback to users. And then, of course, back to remote health monitoring, rehabilitation, which is a huge space. But we want to be able to tell somebody if they've had a hip surgery, what do you need to do? Walk more, walk less? How are you moving? And so this technology is hugely and broadly applicable, and we really can't wait to bring it to market. So I'm Stephanie, inventor and CEO. NASA supports my work on stretchable single-board computers. In the audience is Anjali, my CTO. NSF supports her work on these sensors. Right here is our wonderful scientific advisor and PI, a huge part of our team. And we also want to thank our clinical collaborator, Dr. Brian Koo, here at Yale. So thank you all. You can touch the circuit too, but it's kind of sharp.
Thank you for a really engaging presentation here. One question, and that's on the patent side. So,
Yeah.
what is it? Have you been able
Landscape?
to protect, or what is your strategy around patenting?
Yeah, I totally glossed over it on the videos. We have a suite of 3 patents right now, and we're working on a couple more application-specific ones. The first 2 protect the single-board computer's material and method of making. And the second one protects the breathable fabric strain sensors, which are actually the first of their kind. There are no other sensors that are completely breathable that you can integrate into these clothes.
Thanks a lot. It was a great presentation. I'm curious. There's a lot of solutions aimed at sleep tracking. So can you kind of talk about the incremental benefit that this has vis-a-vis an Oura Ring or an Apple Watch, and sort of the results you have there?
A lot of sleep-based movement disorders would actually be totally missed with that kind of ring. You actually need to be able to detect the movement. Like, for example, REM sleep behavior disorder is characterized by you physically acting out your dreams. So we need to be able to actively reconstruct pose to diagnose these diseases.
Can you talk a little bit about sort of not just, first of all, really impressive in terms of the stretchable, the stretchable circuit, and one could imagine the applications of that are just incredible.
Yeah.
But maybe talk a little bit about the algorithm behind it. Like,
Yeah.
what is unique? Like, you're not just capturing the data. What have you learned about that data, the patterns, all of that stuff that allow you to identify something uniquely?
Yeah. I think a key part of our algorithms will be the deep learning techniques where we can gather a bunch of data on what these kind of motions look like to then be able to give a diagnosis. So that's something that we've like kind of scratched the surface on, but we have the expertise on our team and in our lab to start developing those algorithms.
Should we be thinking about your go-to-market to go to the existing sleep clinics and essentially replacing? Is it as simple as that you attend to, or is this going to be, are you going to market with other clinicians? Are you going to market with directly to patients? How do you think about getting this out into the marketplace?
Yeah, our idea is to sell to clinics.
To the existing clinics, and they replace all the sensors they have now?
Yeah,
Okay.
greatly augment it, yeah. Because like we've observed sleep studies, and it took 2 hours to hook people up to all of these electrodes before they could eventually go to sleep while being watched by, people. So,
How does this circuitry compare cost-wise to what the clinics are using today?
sorry, what was the second word?
How does it compare cost-wise to what the clinics are using today?
All of this is relatively inexpensive. So like the single board computers, every material associated with it is relatively inexpensive, and that's before scaling. And so I would say it's on the order of producing, a normal rigid PCB. And the sensors are just a bunch of fabrics, so also inexpensive. They're all commercial. You could buy them.
So for the fifth presentation, you will learn about innovation in non-invasive fetal brain monitoring.
Good afternoon, everyone. My name is Dr. Emily Lee, and I'm excited to present our work on non-invasive fetal electroencephalography. Every year, over 35,000 newborn babies in the U.S. alone suffer from preventable brain injury at birth. Fetal brain injury is the leading cause of worldwide lifelong disability, the leading cause of childhood death before the age of 5, and a significant contributor to the rising costs of medical care. Birth is naturally a low oxygen state for the baby due to contractions, but dangerously low oxygen states lead to irreversible brain injury and even death. So how do obstetricians identify and prevent this? Currently, we rely on fetal heart rate monitoring to detect low oxygen states in the fetus. However, despite widespread use of this technology since the 1970s, the incidence of cerebral palsy, which is a form of brain injury from low oxygen status, has not decreased, which is shown in blue. Instead, the incidence of cesarean section, which is shown in red, has steadily increased. So what might explain this discrepancy? Heart rate changes reflect downstream effects of oxygenation. Before birth, the baby relies on oxygen delivery from the mother through the placenta. When the baby's brain detects low oxygen states, the heart rate will then respond. However, this reflects downstream effects of low oxygen and can be misleading. As an obstetrician myself, I have personally experienced this discrepancy. In one case, I delivered a baby by emergency C-section due to an abnormal heart rate tracing concerning for imminent brain injury. But after delivery, the baby had no signs of brain injury or hypoxia, thankfully. However, this discrepancy between the heart rate tracing and the actual outcome illustrates the limitations of our current methods. On the other hand, false negatives can also occur from this discrepancy, leading to devastating consequences. In one of the most harrowing cases I've had, I discharged a stable patient from the hospital after a normal fetal heart rate tracing, and she returned less than 24 hours later with a stillbirth. Thus, relying on downstream effects can be costly, with both potential harms to the baby and unnecessary interventions for the mother. So can we shift the paradigm of fetal monitoring and move from current heart rate methods, go upstream and directly measure the baby's brain? The science does support this. Fetal brain activity can be precisely measured by electroencephalography, or EEG. EEG has been long used in adult and pediatric medicine as a primary neurologic diagnostic tool. Importantly, EEG has been shown to be an earlier detector of neurologic damage compared to heart rate changes. So why don't we use fetal EEG if it's that good? Unfortunately, prior fetal EEG required invasive monitoring, specifically attaching a negative pressure suction cup and a metal electrode to the baby's head. This approach, of course, is neither feasible nor safe for large-scale clinical use. Here is where our innovation comes to play. We have harnessed advances in artificial intelligence to develop a proprietary algorithm to non-invasively obtain fetal EEG from the maternal abdomen. The algorithm filters out noise and artifacts from other unwanted electrical signals such as muscle, cardiac, and movement activity. Our innovation correctly identifies and reconstructs the baby's brain activity through EEG. Here is a representative data of A, EEG monitoring from the maternal abdomen without our algorithm with extensive noise signaling, which is clinically useless, B, application of one of our deep neural networks, and C, a finalized clean EEG validated to age-matched newborns reviewed by pediatric neurologists at Yale. Our non-invasive fetal EEG offers significant market potential. We aim to first target the fetal monitoring sector, but this is only one of many applications for this technology. In the US alone, there are over 3.75 million births a year, and we estimate a substantial inpatient demand. There is also significant outpatient prenatal care demand, with projected estimates shown above. Beyond the device itself, recurring revenue streams will come from device maintenance, annual software subscriptions, and replaceable EEG electrodes between patients. While we are in our early stages of research, we have accomplished a lot in less than 2 years and are only gaining momentum. So far, we have developed and refined an algorithm. The research has been funded by an NIH award until this July, and with that award, we have clinically validated the algorithm in a pregnant population. And lastly, we have filed a provisional patent with the help of Yale Ventures. Looking ahead, we want to partner with a team of funders to support our next steps. With funding today, we will continue in our momentum and work towards 2 critical objectives. First, the development of a clinical nomogram and formal validation, and second, development of a wearable device. The funding would go towards our research staff and subject recruitment, EEG machines to increase recruitment capacity, and collaboration with engineers to develop a wearable device that we've already designed. Our ultimate goal is to secure long-term funding for clinical trials to evaluate the impact of non-invasive fetal EEG on the primary outcome of birth injury. Receiving funding today would provide the support we need to build upon our existing traction, advance our work, and ultimately move us closer to translating our research into improving the outcomes for mothers and babies. Thank you so much for your time, and I'd love to take questions and feedback now.
Thank you. I think you did a really nice job explaining the need for higher fidelity monitoring, and from your personal experience, it's great to hear. I'm curious, we've looked at EEG, machine learning before, and I think it's a really exciting emerging field. One of the areas is always, are you device agnostic or do you create your own device? So I'm curious, it sounds like you're going down the path of creating your own device versus leveraging the existing EEGs.
Yeah,
Would love to hear more about that.
That's a great question. So if you know the EEG world, a lot of them, because they're placed on the head, there's wearable caps. So they're kind of like put in a mesh. And of course, you can't put it on a fetus's head. So essentially, when we were testing our preliminary data, we were single-handedly, I was pasting like 20 electrodes on the abdomen. And we thought it would actually be better both for the machine learning side and also for the patient experience to have kind of like a wearable belt. And so it's not really, I would say, high level. It's kind of simple and elegant, is basically embedding these electrodes into like a wearable maternity belt, which is actually on the market for more like support, and kind of sewing these in so that they're always in the same place. So I think actually that simplicity helps us because we're not really reinventing the wheel. We're kind of building on what we know works and is good.
Yeah. So I guess to that point, is the algorithm portable? In other words, could you plug it in to other devices, other backends, other sort of medical systems?
Yeah, that's a great question. That is the ultimate goal, and that definitely can happen. That's usually what's happening in cardiac monitoring right now. So in terms of software-wise, my brother is a software engineer, and he does a lot of this software to hardware. He says that's definitely possible. Right now, with our preliminary data, we've only been working on this for about a year and a half. We actually are doing it, obviously, Dr. Cortez Briones is doing it on his laptop, but that's the goal, is to embed it into a wearable device. That's a great question. Thank you.
So thank you for a very good presentation. High unmet need as well. Our fund does focus on women's health research and startups as well, just for the information here, if anybody has a cool project. So what about competition here? Because I at least have come across other doings, various censoring things, also minimal invasive or non-invasive as well. Have you looked into who you're up against?
So yes, so there's portable, kind of like our previous presenter, there's kind of portable wearable devices that are at home, but they use exclusively cardiac monitoring. And I've actually met that group at our national conference. It's great, you could do that cardiac monitoring at home, but I think really the root of what my experience is, and I think one of the standstills in OB research, is that cardiac monitoring is good, but there is probably something better.
Thank you.
All right. For our next presentation, you will hear about PCDD, and I'll let the speaker explain what that is.
Good afternoon. My name is Claudia See, and I'm excited to present the patient-controlled dispenser and deactivator of liquid oral pain medicine. Our device transforms the way pain is managed. Let me introduce you to a patient. Mary is a 70-year-old African-American woman who just had spine surgery. She is taking opioids for pain medicine. Right now, she must call a nurse every 3 hours to receive one pill. But because her nurse is busy, she's been waiting for 2 hours in excruciating pain. Delays in pain control lead her to have uncontrolled pain, lost sleep, prolonged hospitalization, and even readmission into the hospital 1 week later due to pain. In reality, Mary is just one of 100 million patients every year in the US who need postoperative pain control, but the current modalities are flawed. Currently, patients can receive pills from a nurse. However, there are delays and inconsistencies. Secondly, they can receive liquid medicine through the vein using what is known as a patient-controlled analgesic pump called a PCA pump. However, this is invasive and not indicated for most patients. Lastly, she can receive pills from a PCA box that dispenses pills, but this is prone to diversion. And when we see diversion, we really mean people illegally taking medicines that were not prescribed to them. Over the past 2 years, my two co-founders and I have set out to address exactly this problem. Dr. Jinlei Lee is a professor of anesthesia here at Yale and a nationally known acute pain expert. Dr. Daniel Wisnia is a professor of orthopedics and a former McKinsey consultant, and I'm a fourth-year MD MBA student at Yale and a former R&D engineer at Medtronic. We are supported by a robust team of advisors, including Yale Ventures. Our device is simple. It repurposes a traditional IV PCA pump for oral consumption of liquid medicine, such as opioids. Here's how it works. First, a patient will press a button to dispense a dose. Then the PCA pump pumps the dose into a medicine cup. The patient can then drink this dose by sucking out of a straw, and any excess medication left over will be deactivated in the waste reservoir using activated charcoal and solidifier. Our device revolutionizes pain management because it is personal, it unlocks with RFID fingerprint, it is safe, it eliminates the need to return unused medicine, it is customizable, allowing for smaller dosing at higher frequency, and lastly, it is trackable, providing real-time remote monitoring of opioid consumption. As we developed our device, I spoke with over 50 patients, nurses, pharmacists, and hospital administrators. Patients told me that they really like the independence of our device, and nurses told us that half of their time is spent managing pain, and they rated our device favorably at a 6.4 out of 10. Administrators at the Yale Hospital and the Connecticut Department of Mental Health have also endorsed our device and validate the impact it can have on our patients. Compared to nurse-dispensed pills, PCA pumps, and pill PCAs, our device is truly superior because it is the only one that provides safe, cost-effective delivery of liquid medicine. On the patient side, our device has a user-friendly app interface that shows exactly how much medicine you've taken and also titrates your next dose based on pain level. On the provider side, providers can see real-time opioid consumption data at any time, and they can also remotely adjust prescriptions. Of a total global pain management market worth $27 billion, we anticipate capturing $4.4 billion using liquid opioids and a reimbursement path of marketing to hospitals and reimbursing through insurance. And our beachhead market are patients undergoing major surgeries such as orthopedics and trauma. We estimate saving about $2,600 per device compared to pills, which translates to $1 million of savings with just 380 patients. By 2029, we project to earn $1.2 million by selling 15,000 units across the Northeast. And in terms of milestones, so far we have filed 2 provisional patents and built 3 prototypes. In August of last year, we won the largest innovation award here at the Yale Hospital of $1,050K. And then in October, our device was endorsed by the largest international anesthesia meeting. Right now, we have just signed a contract with a contract manufacturer to build 30 units, and we have also just filed our utility patent. Now is a crucial time for funding, and the 30,000 Bolotnik Award is important to achieve our coming goals. Specifically, we must complete a clinical trial at the Yale Hospital next year, and the bulk of that money will go to support research and nursing staff. Additionally, we must complete FDA regulatory approval through a Q submission to determine our path, and then by filing the actual 510K. In conclusion, our device transforms the way pain is managed and envisions a better healthcare system without pain, overdose, or drug trafficking. Thank you.
Great job, thank you. What's the predicate device for the 510K, and are there other regulatory issues that you have to deal with, just in the sense that you're dealing with opioids?
Yeah, that's a wonderful question. So we have a consultant for regulatory, and we are either going to go through the de novo pathway as an accessory device to the PCA pump, or we will try to use the KYX liquid pump dispenser product category as a predicate. Mm-hmm. But the Q submission is actually really helpful for us to determine in advance. It's kind of like a pre-meeting with the FDA to determine what exactly that path should be. That's a great question. Yeah.
Thanks. Great presentation. Just curious, is this meant exclusively for inpatient use, or is there an outpatient use case as well?
Yeah, that's a wonderful question. So our beachhead market will be strictly inpatient, post-operative patients, but we anticipate a second version of our device that can be taken home and used for any chronic pain management patient. So building our home version of our device in the far future.
Can you talk a little bit about maybe some of the metrics and financial, how big is this problem per patient, and cost of this, implementing it, sort of all of those sort of ongoing.
Yeah, absolutely. And so recently for one of my MBA classes, we took a look at the unit economics, and each of these actually has a study associated. So let me go on to this assumption slide. We anticipate saving money because the hospitalization will be shorter for patients using our device versus pills. Also, readmission will have lower rates, there will be less complications, and patients will be more satisfied with their care, and they will have less pain. And so that's where our value proposition is in terms of saving costs.
Following that, how do you think about starting with integrated networks as far as the payers and where you should initially roll this out?
Yeah, that's a great question. I'm actually not too familiar with integrated networks. Do you mind?
With a payer and a provider being one and the same.
That is something we can definitely
Kaiser,
consider.
like any sort of value-based care.
Oh, that would be a great idea. So far we haven't been able to interview that many insurance companies because they want to see approval or something substantial before they're willing to have a real conversation with us. But we think that there's great opportunity.
Oh, we actually have an easy example. It's called on-cue pumps for the orthopedic surgery now. We do a nerve block, put in the catheter, send patient home. Actually, just with our CAD pumps, that's possible too, but with a disposable pump. So we actually have some CPT code billing systems over there that we can use if we talk to the insurance company.
Thank you.
All right, for our next presentation, you'll hear from Will Sis.
All right.
Sorry, 1 minute.
All right. Good afternoon. My name is Terika McCall, and I'm an assistant professor at Yale School of Public Health in health informatics. So I just wanted to start first with this quote that really kind of grounds me in the work that I do. It's by B.B. Moore Campbell, and it says, "People of color, particularly African Americans, feel the stigma more keenly. In a race-conscious society, some don't want to be perceived as having yet another deficit." And she was speaking about mental health and particularly seeking care. And so this actually, quote, really resonates with me because I've, had a history of anxiety and depression, as well as many of my family members and friends. And one of the things that brought me to this work was trying to figure out how we could leverage technology to deliver culturally responsive mental health services and resources to Black women. So what is the problem? So what we know from the stats is that it's estimated that about 16% of non-Hispanic Black women experience generalized anxiety in their lifetime, and about 27% experience depression in their lifetime. We are seeing a huge issue when it comes to actually seeking care, right? So I recently actually had a survey that I conducted with about 400 Black women, and about 40% said that they needed mental health treatment or counseling within the last 12 months but did not receive it, right? So there is this unmet need there. We also conducted, in addition to the survey, focus groups with Black women who have elevated anxiety or depression. And you can see some of the quotes that came up about their anxiety. Some of them mentioned, or one person in particular talked about being the first person in their family to do a lot of things and how that causes anxiety, as well as another participant talked about trying to be perfect and not knowing how to identify some of the symptoms of anxiety and depression, and then where are the services that they could actually use. So as we had these conversations in these focus groups, what actually came about was this 3-tiered solution. They said, first I want to know, please give me the resources to self-manage. I want that to be the first step. I don't automatically want to jump to go see a therapist. So if you can provide some culturally, relatable resources for me, that'd be great. But then also they talked about the power of community and being able to communicate with other Black women who were experiencing similar things. And so they said, we want an option also to have peer support features. And then lastly, if they needed additional support, they talked about wanting to connect with a mental health professional, especially one who is a Black woman. So they said, it's really, really hard when I do want to find a therapist to actually find a Black woman who's can accept my insurance, one, has availability, and also has availability. So they wanted to be able to streamline that. And so I just wanted to note that, 80% of Black women own smartphones. And so there is, a viable solution in using mobile technology to deliver services to them. So what you see here is just a sneak peek of our prototype, and I'll talk a little bit more about the features on the next slide and how they compare to our competitors. So some of you may know that Shine was recently acquired by Headspace, but they have, they're one of our more, we're one of our more direct competitors. And what you'll note from this slide is that when it comes to things like, having culturally responsive, mindfulness-based cognitive therapy components, WellSys has that. We also have daily meditations, self-care resources, including a self-care planner that actually checks in with them, a guided thought journal, peer support, and also connection to a preferred therapist. So these are all of the features that some of them are still being built into the app, but most of them are in there at this point. So the ones that are being built in, and I'll talk about that in the 6th step in the milestone, is that I talked about us having the focus groups, creating a prototype, really bootstrapped with some CS students. We kind of did this as a part of my dissertation, just on our own, no funding. And it actually tested really well with doing formal usability testing in the lab. So we have 2 publications from this effort. So now we actually completed our sprint for our community and wellness features, and then recently received an award from Google to actually develop the culturally responsive mindfulness-based cognitive therapy components of the app. And so we're going to plan to do that this summer, co-designing with Black women with elevated anxiety and depression and licensed mental health professionals. And so I just want to briefly talk about the business plan. So we plan to offer a free version, but also for businesses, such as insurance companies and organizations whose membership, primarily consists of Black women, offering a premium subscription to their membership in order to actually get revenue. And then lastly, I just want to present the team. I actually have a background in health informatics as well as an MBA and MPH. My team is full of health informatics professionals, UX, UI design experts, and then also experts in mindfulness-based therapy, specifically working with the Black community. And then also, lastly, we have experts in implementation of digital health tools with Dr. David Moore from Northwestern. And I think I'm not too over time. Thank you.
Just wondering how you plan to go to market and reach your target market, especially considering your startup, limited resources, can't rely on quick ads, that kind of thing.
Yeah. So our plan is, after we actually create the therapeutic modules this summer, to actually do a soft launch in the summer of next year. And what we're trying to do now, I'm applying for grants and hoping to get some of these funds to help with the development of this therapeutic content. And so in the summer, once we go to market, primarily through trying to get, we have one partner organization that I didn't mention, which is National Council of Negro Women, which has a reach of over 3 million Black women. So trying to partner with organizations like that, as well as, trying to have some type of big social media campaign around getting the word out. So that's just to start. But then also, we're planning to actually do some pilot testing, because beyond having just another wellness app, we want to make sure that we know that it's effective in reducing anxiety and depressive symptoms. Yeah.
I may be wrong, but my sense is that Shine was very successful around the peer counseling. Is that your sense as well?
So let me just go back one slide. So for peer support, what they had.
And then I guess the following question, which you should ask, is like, how do you make that very special and unique to you? Because I think of all the different things you've got, that feels like something that could be highly differentiated.
Right. Yeah, so their peer support primarily was allowing the users of their app to communicate. For instance, they would post, a thought of the day, and then they would communicate that way. But then they would also host, some workshops, like, for instance, they would have a therapist that would host a workshop or whatnot. But what we're planning to do is to actually allow the users to be able to communicate with each other, through the app, and then also to allow for more structured time. So, for instance, similar to Shine, where we say, we actually have an expert that's coming in to talk about this topic, to allow some conversation and community around that. And then there was also a big, and I know I'm running out of time, but they wanted to be able to meet outside of the app as well. So we're trying to figure out how to foster community outside of the app as well. Yeah.
Any other questions?
All right. Thank you for your time.
Thank you for staying over. Next, you'll hear from a stroke classifier.
Hello, everyone. My name is Richa Sharma. I'm a stroke neurologist at Yale New Haven Hospital. And along with my colleague Ho-Jun Lee, I would like to present Stroke Classifier, an automated EHR-based ischemic stroke etiology classification system. Every year, there are more than 600,000 ischemic strokes in the U.S., and at least a quarter are in people who already have had a prior stroke. Among stroke survivors, another stroke can lead to death or further disability. There are many different causes or etiologies of stroke. Up to 40% of strokes are considered to be cryptogenic, which means no cause is identified after evaluation. The rate of these patients having another stroke is as high as 20%, nearly twofold times higher than in patients with a known cause of stroke. If we can identify the cause of stroke, we can administer targeted evidence-based therapies such as blood thinners and carotid revascularization procedures that are proven to reduce the risk of another stroke from that specific etiology. However, these treatments are significantly underutilized both in the US and globally. There are several reasons why secondary stroke prevention therapies are currently underused. First, there may be uncertainty regarding the cause of stroke, which requires synthesis of a large amount of complex data from a stroke hospitalization. Secondly, there's a shortage of stroke expertise. Only 1 in 6 stroke patients in the US is treated by a board-certified vascular neurologist. Finally, clinicians may be slow to implement guideline-recommended therapies for specific causes of stroke without prompting. To optimize the use of secondary stroke prevention, we developed and validated an automated clinical decision support tool, Stroke Classifier, which classifies the underlying cause of stroke as accurately as vascular neurologists and can resolve diagnostic uncertainty in patients deemed to be cryptogenic by vascular neurologists. This tool analyzes EHR data and provides a predicted cause of stroke as well as guideline-directed therapy recommendations. Stroke Classifier was trained on over 2,000 discharge summaries from ischemic stroke hospitalizations at 2 large academic comprehensive stroke centers. We tasked machine learning classifiers to predict the cause of stroke as determined by a consensus of 2 or more board-certified vascular neurologists who reviewed the entire medical record. Using natural language processing, we engineered over 2,000 clinical, radiographic, and laboratory features and built an ensemble model of 9 machine learning classifiers. We performed multiple cross-validations and externally validated the algorithm in the MIMIC3 dataset. The output of Stroke Classifier is an automatically generated recommendation report that lists the predicted stroke etiology and guideline-recommended therapy. It also lists other risk factors for stroke for the individual patient and interventions to consider implementing. Finally, it pinpoints any gaps in diagnostic testing. This report can be placed as a progress report in the EHR to be informative but not intrusive in a clinician's workflow. Furthermore, it is adaptable to multiple different EHR systems. In terms of added value, Stroke Classifier rivaled vascular neurologists with an accuracy rate of 75% internally and 69% externally. As a comparator, a trained data abstractor for the Get With the Guidelines Stroke Registry at Yale has an accuracy rate of 57%, while a non-vascular neurologist at Yale had an accuracy rate of 56%. Furthermore, when applied to the EHR of patients deemed to have a cryptogenic stroke by vascular neurologists, Stroke Classifier predicts a specific etiology in 73% of cases. This indicates a potential advantage of Stroke Classifier to process, analyze, and find patterns in high-dimensional data generated during the stroke hospitalization in patients otherwise determined to be cryptogenic by human vascular neurologists. Stroke classifier takes into account more than 2,000 different clinical, radiographic, and laboratory features to generate its prediction with varying weights for each predicted etiology. Here are the top 10 most predictive features, which mirror factors I regularly use and other board-certified vascular neurologists use when diagnosing the cause of stroke. While there are currently AI products used in the field of stroke, their sole purpose is to help clinicians, such as myself, administer therapies to abort an ongoing stroke. Stroke Classifier is the only automated tool for secondary stroke prevention. The annual cost that hospitals currently pay for stroke expertise ranges from $5,000 to $25,000 for rapid AI and telestroke, up to $195,000 for the salary of a vascular neurologist, amounting to a lower end of nearly $28 million from the 5,500 hospitals in the U.S. We will be able to charge an annual subscription fee comparable to existing stroke solutions and potentially provide cost savings from labor reduction. We next plan to test Stroke Classifier's clinical utility in a multi-center clinical trial, and the Blavatnik funding would be used to support the effort of a data scientist to integrate Stroke Classifier in the Yale New Haven Health System EPIC. Thank you.
Thanks a lot. That's a great job. I think you were getting to a little bit at the end there, but could you just maybe talk a little bit about the business model and how it would sort of incorporate into how a hospital would make this purchase decision?
Absolutely. So currently, hospitals utilize external stroke expertise to provide guidance to local hospitals without on-site local neurologists about whom to treat with TPA, whom to treat with thrombectomy. And it's on a basis of an annual subscription fee to Rapid AI and Viz AI. And we would envision that this would be a similar annual subscription fee.
You compared your effectiveness to an actual person, but what about the other, digital solutions? How do you compare to them?
The other digital solutions have a completely different purpose. Those solutions look at imaging, CT, CTA, MRI, in real time to determine how much of a brain is dead and how much is potentially salvable to determine that this particular patient is a very good candidate for clot removal. So that's in the acute phase where we're trying to save brain by aborting the stroke. This is to prevent stroke. And there's no such solution on the market.
Nobody else is looking at medical records to predict stroke?
To predict stroke etiology. We have a provisional patent.
It's really interesting to see the amount of cryptogenic that can be potentially diagnosed. What level of accuracy do you think you need to change management, right? There's one thing to say, we don't know what it is, so we're going to watch and wait, versus we're going to now prescribe something new, which could have negative side effects if we're wrong.
Absolutely. And so I think that's the next level, next phase of our study is to truly identify among those who we deem to be non-cryptogenic based on our algorithm with long-term follow-up, how many of them are converting. And so I think that would be very informative information.
Thank you for a good presentation. What about the regulatory path? Has that been cleared out for you? I mean, if you're both doing diagnosis, risk scores, and treatment guidance, so how will that look like?
That's a very good question, and one I haven't even considered at the moment, and it would require some guidance from legal and Yale Ventures to really outline what that would look like.
Quick question, maybe, if we have time. So the data you're gathering is from here?
So it's from Yale New Haven Hospital, Massachusetts General Hospital, and then Beth Israel Medical Center in Boston, which has publicly available data.
Okay. And do you foresee that you need to expand that data set and get more? Okay.
We have just had our IRB approved through the Veterans Affairs Medical Center, which is comprised of over 100 hospitals. And so I think we're very interested in seeing the generalizability of our algorithm and to iteratively improve it.
Thank you.
Thank you. So for our last and certainly not the least presentation, you'll hear from Overdose Guardian.
Thank you all for sticking around. My name is Chandra. I'm an undergraduate at Yale and co-founder of Overdose Guardian. We're building a safety net for opioid overdose. Gorge's overdose tells a powerful story about the deadly silence before detection. A staggering 20 minutes of Gorge's 28-minute overdose went undiscovered. This delayed detection culminated in a debilitating brain injury for Gorge and exorbitant expenses for his insurance and for his family. The urgency of overdose treatment cannot be overstated. Just 6 minutes without breathing causes irreversible damage, but this isn't just a human cost. The healthcare system is burdened with over $20,000 each time an overdose is treated in the ICU, and the scope of this problem is immense. Each year, over 60,000 fatal overdoses fly under the radar undetected. But these aren't just numbers. These are devastated families and a healthcare system stretched thin. It's clear that we need a solution. Our solution is a wearable overdose alert device. It minimizes the duration of an overdose, reduces the need for inpatient admission, and ultimately saves lives. Think of it like a life alert for opioid overdose. The software collects SpO2, or blood oxygen saturation data, processes the photoplasmathography waveform, and uniquely identifies opioid-induced respiratory depression. This allows for real-time tracking of vital signs and faster detection of potential overdoses. The hardware is discrete and equipped with a medical-grade pulse oximeter, and when an overdose is detected, it'll sound a loud alarm and then send an alert to emergency preset contacts and emergency medical services. Our users value its low-key appearance. In a recent study, 71% of patients with opioid use disorder expressed willingness to wear an overdose guardian device. Our technology relies on trusted hardware and software. To collect SpO2 data, we use the gold standard Novometrics OxyPlex pulse oximeter. This ensures accurate, reliable measurements. To process this data, we use patented Yale methodology, a proven method for determining peripheral venous and arterial plasmathography saturations. Overdoses are identified using a trade secret SVM algorithm. This algorithm is able to identify early signs of respiratory depression with precision. Once an overdose is detected, then a secure Bluetooth and millimeter wave Verizon 5G connection will alert first responders, initiating an automated national emergency dispatch workflow. We've tested components of our MVP on databases. We are analyzing 220 OUD patient data from Dr. Henry Yagi's study from the Yale Addiction Medicine Program and Sleep Medicine Program, and our algorithm showed promising performance. With 79% accuracy and remarkable 98% specificity, our algorithm showed its ability to accurately and reliably detect cases of respiratory depression. We have many potential customers. Our beachhead are addiction medicine and rehabilitation clinics who spend $460 million annually for purchasing supplies like Overdose Guardian. But this is just the beginning. Hospital systems could significantly reduce the nearly $2 billion they spend annually treating overdoses. We could license our software to wearable device companies like Apple or Fitbit, and there's a direct-to-consumer market too. Imagine a mother scared for her teenage son battling addiction. Imagine the loved ones of a grandmother who recently went through surgery. These are all potential customers, financially and emotionally burdened from overdose and seeking to ensure the safety of their communities. Our competitive landscape includes an FDA-approved device. The Masimo FDA-approved safety net detects overdose in hospital settings. Other early-stage companies are using other methods of detection, like sonar, for example, and other medical alert devices like ePill, pill connected to Apple Watch offer very basic at-home detection. However, we offer unique competitive advantages. Masimo's predicate device offers streamlined FDA approval for determining our substantial equivalence. Our product's discrete appearance uniquely enables users with the comfort and privacy for at-home use. Our technology is developed at Yale, and our integration with emergency dispatch services provides a quicker, seamless response to overdoses, ensuring rapid treatment. Our product is not just competitive, it's designed to surpass the existing alternatives. Our experienced Yale team is led by women founders. Today, I am pitching on behalf of co-founder Dr. Min-Hee Sung, an addiction medicine specialist at Yale, with over 16 years of clinical research experience and 17 publications. Securing the blood prize would be a game changer for us, accelerating the rollout of our device. $6,000 will go towards extending existing efforts of technology improvements and feasibility improvement, and $24,000 will go towards 2 pilot validation studies. We received pilot interest from a hospital in the Lansing, Michigan area, and also several addiction medicine clinics in the New Haven area. Together, we can transform the fight against the overdose epidemic, saving lives and creating a better future. Thank you.
The specificity numbers are compelling. I think the sort of false positive issues would be really overwhelming. Do you think you need to get the sensitivity up from where it is, and where do you think you really make, people really pay attention to it? Sort of 85, 90% north. Do you think you need to get to there in order for this to be successful?
Yeah, absolutely. I think increasing our sensitivity and decreasing those false positives is our utmost importance. I think there are two things to be said about this. First, to get FDA approval, all we need to show is substantial equivalence to Masimo's device, which is widely adopted in hospital settings. And secondly, the advantage of using machine learning and software as our innovation point specifically allows for personalized algorithms. So the user being able to click on their device whether they're not overdosing. Let's say it sounds an alarm, like, oh, I'm actually conscious, I can set that. They'll click a button, and that redefines the hyperplanes for our support vector machine. With future installments of artificial intelligence, this will redefine the weights and biases in a convolutional neural network, for example. So I see this number going up, and specifically testing this in wider populations going up as well.
Thank you for the presentation. Huge need. How do you think about ensuring that patients and individuals wear the...
Absolutely. So we've talked to a lot of frontline harm reduction centers, and they have in-place methods of really increasing patient engagement. So we've seen mobile MAT vans. We've talked directly to frontline workers, and that personalized relationship has been proven really effective to get these people in these programs. And we think that combined with the community effort of people wearing this device will really increase that engagement.
Talk a little bit about alternative ways to go to market, right? Because it's very hard to sell a device, hardware, it's expensive to produce, and is there embedded ways in which you can sort of more quickly get into the market with faster adoption?
Yeah, that's a great question. I think that's why Software Play has licensing up there in the first place. I really do think that MAT is a data-term addiction and rehabilitation clinics is the right way to go. We specifically know, and we have advisors that have charted us through the funding route and have showed us exactly where they can purchase our device from. So it really does seem like the most accessible. But D2C is always out there, just like Masimo's device.
Any other questions?
So what about the intrapersonal, if you sweat, if you have been doing, are there any confounding factors in there that you need to cater for in your system? Not to set off false alarms or something?
Yeah, absolutely. I think SVM specifically do a great deal to denoise the data. Having reliable hardware does